Welcome to This Week in Neurosurgery. This week we are covering 10 notable papers spanning neuro-oncology, functional neuromodulation, and neurovascular interventions. Let us dive in. We begin in the realm of cranial neuro-oncology and perioperative management, where optimizing patient selection, predicting complications, and refining postoperative recovery protocols are vital to enhancing surgical outcomes. First, in a study, researchers investigated how to improve the prediction of postoperative delirium, a common and debilitating complication affecting nearly 20% of patients undergoing elective craniotomy. Sun and colleagues conducted a secondary analysis of 800 adults, identifying age, educational level, the nature of the intracranial lesion, and supratentorial location, along with operation duration, blood loss, and intraoperative hypotension as independent risk factors. By integrating preoperative frailty, measured using the 5-factor modified frailty index, the investigators demonstrated that a super-early prediction model relying solely on preoperative data performed comparably to a more complex model requiring intraoperative variables. This allows clinicians to accurately stratify delirium risk before surgery and initiate proactive, targeted preventative measures. Once the patient is out of the operating room, managing cerebral edema while minimizing steroid-related side effects remains a critical concern. In a separate propensity score-matched cohort study of 232 patients with newly diagnosed glioblastoma, Lin and colleagues evaluated a short-course, high-dose methylprednisolone regimen against no postoperative steroids. Patients receiving 500 milligrams of methylprednisolone daily for the first 3 postoperative days experienced a significantly shorter median hospital stay of 11 days, compared to 12.5 days in the non-steroid group. Remarkably, the methylprednisolone regimen was associated with a complete absence of postoperative deep vein thrombosis, dropping the incidence from 6% to 0%, without increasing steroid-related complications or negatively impacting overall survival. Accurate mapping of motor function is essential to safely maximize resection in motor eloquent gliomas. A study published in Neurosurgery explores how preoperative navigated transcranial magnetic stimulation can characterize what the authors call the brain's neuronal reserve capacity. Jefferson and colleagues analyzed data from 194 patients and found that an unstable compensatory capacity, characterized by hyperexcitability and inadequate recruitment in the tumor-affected hemisphere, strongly predicted baseline adjusted motor deficits. Specifically, a reduced resting motor threshold ratio and an elevated recruitment curve slope ratio were independent predictors of motor impairment, alongside shorter tumor-to-tract distance and recurrent tumor status, while female sex was protective. When these patients proceed to surgery, the choice between awake and asleep motor mapping is a common clinical decision point. Writing in the Journal of Neuro-Oncology, Trippett and colleagues compared these two modalities in a cohort of 130 patients undergoing peri-Rolandic diffuse glioma resections. The investigators found that 3-month motor deficit rates were equivalent between awake and asleep mapping, at roughly 5%. And no deficits were observed in either group for patients with isocitrate dehydrogenase mutant gliomas. Additionally, within the asleep cohort, safety and deficit rates were comparable whether surgeons used a handheld probe or subdural electrode direct cortical stimulation, supporting asleep mapping as a highly viable alternative when awake craniotomy is not feasible. Moving to functional neurosurgery, recent studies highlight technological advancements that are streamlining procedures and expanding treatment options for complex movement disorders. In a study, Osakata and colleagues evaluated the use of automated atlas segmentation software, specifically BrainLab Elements, to plan magnetic resonance imaging-guided focused ultrasound ventralis intermedius thalamotomy. In their retrospective analysis of 80 patients, the clinical tremor improvement rate did not differ between the automated segmentation group and the conventional landmark and manual atlas group. However, the automated segmentation group required significantly fewer intraoperative target adjustments and fewer sonications, averaging 6.7 sonications compared to 9 in the conventional group. This suggests that while clinical efficacy remains high with both methods, automated atlas segmentation significantly increases procedural efficiency and reduces energy delivery. For patients with complex or mixed movement disorders that do not respond to traditional single-target stimulation, a novel, network-based approach is showing promise. Also in operative neurosurgery, Sherman and colleagues presented the largest case series to date on multinodal deep brain stimulation, evaluating 14 patients with mixed movement disorders. By successfully implanting more than 2 deep targets through only 2 burr holes and connecting them to a single 32-channel pulse generator, the authors achieved significant reductions in the Unified Parkinson Disease Rating Scale for complex Parkinson disease and the Clinical Rating Scale for tremor for complex tremor without any intraoperative or postoperative complications. Further expanding the boundaries of restorative neurosurgery, a landmark clinical trial published in Science Translational Medicine provides the first long-term safety and efficacy data for intracortical microstimulation in humans. Greenspan and colleagues followed 5 participants with spinal cord injury who were implanted with microelectrode arrays in the hand representation of the somatosensory cortex to restore a sense of touch. Over implant duration spanning up to 10 years, representing a combined 27 years of data and more than 168 million delivered pulses, there were no serious adverse events or negative effects on electrode health. Although detection thresholds slowly increased by approximately 3.5 microamperes per year, nearly 2/3 of the electrodes continued to reliably evoke tactile sensations, including 60% of the electrodes in a participant followed for a full decade. The quality and localization of the evoked sensations remained highly consistent, demonstrating that intracortical microstimulation is safe, durable, and highly viable for permanent sensory restoration. In the neurovascular domain, endovascular stroke therapy and aneurysm treatment continue to undergo rigorous evaluation to determine if technical modifications translate into clinical superiority. A single-center, randomized controlled trial of 170 patients. The modified technique utilized EmboTrap 3 thrombectomy stents and partial retrieval of the stent with an aspiration catheter. While the modified technique achieved significantly higher rates of first-pass effect and modified first-pass effect, it did not significantly improve the primary outcome of functional independence at 90 days, which was 56% in the modified group and 51% in the standard group. Because successful reperfusion, symptomatic intracranial hemorrhage, and mortality rates were nearly identical between the groups, these procedural advantages did not lead to better clinical recovery, highlighting the gap between angiographic success and functional outcomes. In the treatment of intracranial aneurysms, surface-modified flow diverters are designed to reduce device thrombogenicity and potentially allow for safer or simplified antiplatelet regimens. A systematic review and meta-analysis. Encompassing 176 aneurysms treated with the DERIVO2 heel embolization device, which features a fibrin and heparin-based surface coating. Konduja and colleagues reported a pooled periprocedural ischemic or hemorrhagic complication rate of 7.1% and a technical complication rate of 9.3%. Complete angiographic occlusion at roughly 6 months was achieved in 79% of cases, with no treatment-related mortality. While these occlusion and safety rates are acceptable, the authors concluded that the current literature does not demonstrate a superior safety profile for this coated device compared to established uncoated alternatives, emphasizing the need for prospective, comparative trials to define its true clinical benefit. We conclude this week's review with a look at spine surgery, specifically transforaminal lumbar interbody fusion, or TLIF. It is often assumed that younger patients, owing to superior biology and fewer comorbidities, will achieve better surgical and functional outcomes. A propensity score-matched cohort study in the Journal of Clinical Neuroscience challenged this assumption. Sharma and colleagues matched 89 patients aged 50 or younger with 178 patients over the age of 50, who underwent TLIF for degenerative pathology. Over a minimum 2-year follow-up, there were no significant differences in complications, reoperations, pseudarthrosis, or cage subsidence. Interestingly, older age was an independent predictor of adjacent segment disease, with roughly double the risk compared to the younger group. However, older patients actually demonstrated significantly greater improvement in patient-reported outcomes, including back pain, leg pain, and disability index scores. This suggests that younger age does not guarantee a lower risk of surgical failure, and that older patients may experience a more pronounced perceived benefit from the procedure, which is critical information for preoperative counseling. If you only have time for one paper this week, make it the long-term study on intracortical microstimulation in Science Translational Medicine. This landmark clinical trial provides unprecedented 10-year safety and efficacy data for human brain-computer interfaces, proving that intracortical electrodes can safely and consistently restore sensory function over a decade without causing serious adverse events or losing functional integrity. Here are the key takeaways from this week in neurosurgery. First, in patients undergoing elective craniotomy, integrating preoperative frailty using the 5-factor modified frailty index significantly improves our ability to predict postoperative delirium before surgery, allowing for early intervention. Second, utilizing a short course of high-dose methylprednisolone for 3 days after glioblastoma resection significantly reduces hospital stay and deep vein thrombosis rates without increasing complications or affecting survival. Third, awake and asleep motor mapping techniques yield comparable 3-month neurological outcomes for peri-Rolandic gliomas, confirming asleep mapping as a safe and reliable option. Fourth, younger age does not protect against surgical complications or radiographic failure after transforaminal lumbar interbody fusion, and older patients often experience greater subjective functional improvement. Finally, multinodal deep brain stimulation using multiple targets through only 2 burr holes connected to a single generator is a safe and effective strategy for complex, mixed movement disorders. That's your roundup for this week in neurosurgery. The full transcript and references are available on the episode page in your AudioScholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.